So, asthma is a chronic inflammatory disease of the pulmonary airways. The inflammation leads to increase in airway reactivity and responsiveness. It is characterized by airway inflammatory cells, inflammation resulting in acute, subacute, and chronic process that alters airway tone, airway hyperresponsiveness, and airflow obstruction. So, things to take away is that this is a chronic inflammatory disease and it's also a reactive airway disease. Epidemiology of asthma. It's associated with atopy. Atopy patients who have atopy exhibit atopic dermatitis, allergic conjunctivitis, allergic rhinitis, and asthma. The epidemiology is that 21 million patients in the United States have asthma. In 2002, there were 14.4 million outpatient asthma visits to primary care provider offices and hospital clinics. African Americans had an office visit rate of 40% higher than whites, and asthma deaths have leveled off with about 4,000 in 2001. This leads to 465,000 hospital admissions annually. The pathophysiology of asthma. So there's two main components. Smooth muscle dysfunction with hyperplasia and hypertrophy manifest as bronchospasms. Okay? And then infiltration of inflammatory cells, mucosal edema, microvascular leakage, and epithelial damage leads to airway inflammation in response to airway hyperreactivity and hyperresponsiveness. So that's where we get that many times you'll hear of asthma as being a reactive airway disease. The main cause of airway obstruction is that there's contraction of bronchial smooth muscles resulting from enhanced contractibility in response to mast cell-derived mediators. So it's an immune response. Edema in the airway due to increased permeability of small vessels plays an important role in limiting the airflow. The lumen of the airway becomes obstructed by thick copious secretions and infiltration of eosinophils and lymphocytes, forming a mucus plug. This is derived from hyperplastic mucus-producing goblet cells and submucosal glands. So all of this inflammation ends up causing thick secretions, which then can cause a plug. Airway remodeling. So airway remodeling is a hypertrophy and hyperplasia of airway smooth muscles and goblet cells that leads to deposition of collagen in the basement membrane stone and an increase in size and number of blood vessels and the submucosa. So it's almost like you think about asthma and you think about peripheral vascular disease and how the blood clots, because of the clogs, will form new ways to get the blood flow around. The same thing. Because of all this and the hyperinflammatory process, they get an increase in number of blood cells and blood vessels. This is to be responsible for the irreversibility of airflow observed in some individuals with asthma. So the functional consequences of these pathologic changes are the airway becomes narrow and the airway resistance increases. So the airway resistance increases and results and it becomes more narrowed. Asthma symptoms. So the cardinal symptoms you're going to have patients complain about is a cough, which usually is a dry, hacking type cough, and then a wheezing with shortness of breath. And that shortness of breath can feel like their chest is tightening and chest pain. The patterns of symptoms, they can be perennial, seasonal, so sometimes it's based on they know that certain weather changes or head cold seasons is when they're going to have their symptoms. Sometimes it's episodic or continual, and then sometimes it's diurnal. So it kind of depends. You'll have different patterns and people will know their asthma and their asthma triggers, which is where when they're younger, they should really be looking for their triggers such as seasonal weather changes, if it's episodic with colds, or is it they constantly have symptoms. Differential diagnoses would be COPD, especially in our older adults. We want to rule out, is it COPD or is it asthma? Is it bronchogenic carcinoma? Is it obliterative bronchiolitis? Is it eosinophilic bronchitis? Is it bronchostasis, vocal cord dysfunction? Angiotensin converting enzyme inhibitors that cause that dry cough. So if it's somebody that is a hypertensive and they're on an ACE inhibitor, is the cough because of that? Or is it acid reflux, which also can cause a cough? Asthma history. So patient symptom history. We want to know their daytime, their nighttime symptoms. We want to know, does it interfere with their activity level? So can they jog? Can they do their normal activity? Or are they having symptoms? At night, are they waking up and coughing due to this? The number of the times the patient has to use their quick relief medication, so their albuterol. Our goal is to get patients to use it 3 times or less in a month. If they're using it more than that, we need to know. Now, that's separate from them pre-medicating. Some patients will pre-medicate before exercise as they know that's a trigger for them, so that's different. How many emergency room, hospitalization, urgent cares have they had in the last 6 months? How many missed days of school or work have they had? And they have the ability to maintain normal activity level. Classification of asthma. The classification is based upon frequency of their symptoms, frequency of exacerbations, nocturnal symptoms, their FEV1, their compare to predicted or peak expiratory flow rates, in relation to their personal best or diurnal variability of their PEF. Elderly. It's often overlooked, or they think it's, they have chronic bronchitis. So you have to really think about, some people will develop asthma later in life. I can use myself personally. I always, as a kid, would have occasional asthma attacks. But then whenever I would get pregnant, I constantly had asthma attacks. And so I actually had to advance myself up. I'm not an intermittent asthmatic anymore. I'm more of a moderate persistent asthmatic. So that's one thing that patients too, you can't overlook that they have this history, family history. We need to make sure we're ruling out, is it asthma? And the elderly, valid spirometric results are more difficult to obtain, and exercise may be dangerous for them too. Manifestations of asthma. So several forms of asthma for discussion. Occupational asthma, cough variant asthma, nocturnal asthma, and exercise-induced asthma. So some of these terminologies have also gone away with newer guidelines. Exercise-induced now is more intermittent asthma. But these are things we have to look at and think about, especially occupational. They work in an environment, they're working with dust or they're working with drywall. They could get asthma that's not typical asthma, it's occupational asthma. So we need to kind of evaluate these. Exacerbations of asthma. A number of factors are known to cause exacerbations. The main trigger to asthma exacerbation is exposure to an agent to which the patient becomes sensitized. So they're allergens. We need to have them track what their triggers are. Sometimes all of a sudden it's certain perfumes or triggers like that. Sometimes it also can be triggers of common cold. So kind of figuring out what are their triggers that causes their exacerbation and knowing that. And like I said, sometimes it's seasonal. History, early in life. History of chronic rhinitis with episodic wheezing sometimes gets overlooked in children, and so then they actually always had asthma, but it's not till adulthood that we realize it. Coughing at night or in the early morning hours, many times people just associate that with their allergies, or they think, oh, it's just that's how I am, and don't realize that that's truly a sign of asthma. Shortness of breath and wheezing with exercise. A family history of asthma or allergies, and response to asthma pharmacology. How do they respond to albuterol? How do they respond if they ever get put on Qvar, Flovent, and looking at that. The Baylor's Rule of 2. More than 2 uses of a quick relief inhaler per week. More than 2 nighttime awakenings for asthma per month. And more than 2 quick relief MDI canisters per year. We need to reassess their therapy. They are not controlled. We need to bump them up based on the symptomology and probably bump up their therapy. Physical examinations. Findings vary with the severity of the airway obstruction. Mild intermittent asthma might be just physical activity, and it may be normal. Mild to moderate persistent asthma, expiratory wheezing, most common, and inspiratory wheezes may be heard. Severe persistent asthma, their hyperinflation of the chest with an increase in the AP diameter may be seen. And since allergic rhinitis frequently coexists with asthma, remember to examine the nasal passages. Look at the airways. Do they have, underlying polyps we never realized? How do their nares look? Do they have turbinates that are hypertrophic and that are blue? We need to do a head, ear, nose, throat, lungs, heart, skin exam on all of these patients. With asthma, any patient with asthma, you need to do head, ear, nose, throat, skin, because as we know, many times they have that atopy. Check for hyperexpansion of the thorax, use of accessory muscles, wheezing or prolonged expiration. Physical exam of the chest may be normal as well. So measures of pulmonary function, spirometry. Initial diagnosis or to reassess or confirm the diagnosis we need to do. So anytime you initially diagnose them, you need to have them get a spirometer and check their results. And then we need to reassess at visits, and we need to confirm the diagnosis. After treatment is initiated or changed, we need to reassess their spirometry. Once symptoms and PEFR are stabilized, to document attainment of near normal pulmonary function, at least every 1 to 2 years to assess maintenance of airway function, and more often as severity indicates. Okay. We need to use for follow-up, and it's not to diagnose it. Okay. Uses of peak expiratory flow, acutely assess severity and exacerbation, and patients need to be taught how to use their peak flow meter correctly so that they can know. So we can know when they're in the green, the yellow, or the red zones. So for acutely, if they know what their personal best is, they should do this if they feel like they're starting to have symptoms and see, oh my gosh, my peak flow's decreased. Maybe I need to do some albuterol more frequently. Short term, to evaluate their therapy, establish temporal relationship to triggers. Long-term, detect changes in disease status, evaluate treatment, and provide patients with a written action plan, which is a key. In pediatrics, we're really good about giving action plans for our asthmatics. We need to do it in our adult patients. I think if more providers did it with asthma patients for their adult patients, we would have less issues with patients not understanding and not being compliant with their medications, because many times our patients, even adults, do not understand what their inhaled corticosteroids are versus their albuterol. They'll think that those are also just for acute relief, and those need to be taken daily. Intermittent asthma, so symptoms less than 2 days a week. Nighttime awakening is less than 2 times a month. Short-acting beta agonists, they use their albuterol less than 2 days of the week. Interferes with normal activity. They should not have any if they're intermittent asthma. And lung function should have a normal FEV1 between exacerbations. FEV1 over 80% predicted. Okay, and their FEV1 to FVC should be normal. Your mild persistent asthma, and I would memorize these different details. In clinical, when you're at practice, there's apps you can download that give you this information. You can print out the guideline algorithm, but these are things you get used to in practice to know, and you should know these because you don't have to look these up every time you see an asthma patient. They kind of become second knowledge once you get used to using them, but these are how you're going to know if a patient is controlled or if they need to be bumped up with their severity. So for your mild persistent asthmatics, their symptoms are over 2 days of the week, but not daily. Nighttime symptoms are 3 to 4 times a month. Short-acting beta agonists, they're using their albuterol over 2 days of the week, but not every day. Okay. Interferes with normal activity is minor limitations. Maybe this is one who they have seasonal interaction. They can't go for that long run without having to use their albuterol before or after. Their FEV1 is over 80% predicted. The FEV to FVC is normal. Your moderate persistent asthmatic symptoms are daily of a dry cough, maybe not necessarily wheezing, but they're having symptoms daily. They know their asthma symptoms. Nighttime awakening is over 1 time per week, but not nightly. Short-acting beta agonists they're using daily. Interferes with normal activity is some limitations. And their lung function, their FEV1 is over 60% predicted, and their FEV to FVC is still normal. Your severe persistent symptoms are throughout the day. Nighttime awakening is often 7 times per week. Short-acting beta agonist is several times a day they're having to use. They have extreme limitations of normal activity, and their FEV1 is less than 60% predicted, and their FEV to FVC is reduced over 5%. So impairments, the expected normal FEV to FVC is going to be your 8 to 19-year-old is 85%, 20 to 39 is 80%, 40 to 59-year-old is 75, and as we age, it gets less. We cannot do forced air velocity as quite as much. Levels of asthma control: well controlled, not well controlled, and very poorly controlled, okay? And this is based on how many symptoms they're having, how often you use their albuterol, okay? And if they had exacerbations. Control impairment risk. So I'm not going to read this over with you, but this goes one over the kind of symptomology we talked about with how often they're having their symptoms. And you're also going to look at their FEV1 for this, okay, or peak flow. To kind of determine, are they well controlled, not well controlled, or very poorly controlled. The asthma, acute asthma exacerbation. So peak flow at this point is less than 50% predicted normal. The failure to respond to the beta-2 agonist, so they're doing albuterol and not quite responding. Severe coughing or wheezing, or I will say with the failure to respond, they get response, but they're having to use that albuterol again before that 4 to 6 hours. Severe coughing or wheezing, extreme anxiety due to breathlessness. They're gasping for air, sweaty, and cyanotic. They have rapid deterioration over a few hours. Severe retractions and nasal flaring, and hunched forward because they cannot get enough air in. Treatment of asthma. According to the Asthma Education and Prevention Program, there are 4 components. We want to use of objective measures of lung function to assess severity of asthma and to monitor results of therapy. Implementation of environmental control measures designed to avoid or eliminate factors that contribute to asthma severity. Use of pharmacologic therapy that treat asthma exacerbation and modulates on a long-term basis the airway inflammation that is an intrinsic component of the disease. And implementation of patient education programs with the purpose of not only educating programs with the purpose of not only educating patients and their family, but to establish a partnership between the healthcare provider and the patient family for asthma management. The goals of asthma therapy is to control symptoms to prevent exacerbations. We want to maintain normal activity levels, including exercise, maintain pulmonary function as close to normal as possible, and minimize adverse drug reactions or drug effects. The stepwise approach to asthma. Stepwise approach of therapy emphasizes initiating higher levels of therapy at onset to establish prompt control and then step down. We do not want somebody always being a severe persistent. We want them to get down to at least a mild persistent asthmatic. Treatment is initiated according to the patient's highest component of severity. So this is kind of the stepwise approach of how we would assess a patient on their severity. And like I said, patient is reassessed in 2 to 6 weeks for effectiveness of therapy. When patient is controlled for 3 months, therapy is stepped down. So we don't want somebody to be on all these medications forever if we can step down and get things under control. Remember, it's an inflammatory process. If we can get the inflammation under control, we can hopefully step them down with that. So usually once I change patients' medication, I want to see them back in a month to reassess. So 12 plus years for the stepwise approach, it kind of shows you if they're step 1, they're just on a short-acting beta agonist, PRN is needed. Step 2, they're on the low-dose inhaled corticosteroids. So example is if you did QVAR, you'd have them on the 40, and then if they were the medium inhaled, once they're a moderate persistent, that would be the 80, or you could still do the 40 with adding on a LABA. If they're severe persistent, we want to consult an asthma specialist. Drugs for treatment of asthma. There's 2 different categories. There's relievers and there's controllers. Okay, relievers are things we want to take short term, just whenever we are having symptoms. Okay, anybody in any of these steps can be started on any of these, okay? All asthmatics should be on albuterol at the least, okay? And then if a patient needs it, any patient, if they're mild persistent and they're having an asthma exacerbation, we want to give them oral corticosteroids. We want to give them prednisone to decrease that and get them back down under control. That's only for acute exacerbations, but if they need it, they get that at that point, okay? Controllers are things like your cromolyn, your Singulair, your inhaled corticosteroids, okay, your anti-IgE therapies, and add-on therapy. So the aim of asthma therapy is to maintain control of asthma with the least amount of medication and hence minimize the risk of adverse effects. Therefore, a step approach is used to manage asthma in adults and children older than the age of 5. Medication overview. So long-term control is your inhaled corticosteroids, your long-acting beta agonists, which would be your LABAs, your leukotriene modifiers such as Singulair, your inhaled non-steroidal anti-inflammatory agents, and your methotrexates. Quick relievers are your short-acting inhaled beta agonists, your anticholinergics, and systemic corticosteroids. Quick medications, so provide prompt relief of acute airway obstruction and accompanying symptoms such as cough, chest tightness, shortness of breath, and wheezing. Medications, like I said, include your short-acting beta agonists, your oral steroids, okay, and anticholinergics. So long-acting beta agonist. Onset of action varies with specific drug use. Duration of action is over or equal to 12 hours. They improve symptom scores and lung function, decrease nocturnal asthma, use of short-acting beta agonists, and number of exacerbations. Adding to current inhaled corticosteroid dose gives better asthma control than increasing the current oral corticosteroid dose, okay? So that is something to think about. If you have someone on a low-dose inhaled corticosteroid, if you add on a LABA with that, if they need it, that does better control than just increasing the inhaled corticosteroid. And like I said, they may be combined with your inhaled corticosteroid for treatment of persistent asthma. Does not replace, though, the short-acting beta agonist. Like I said, every asthmatic should have a short-acting beta agonist in their on their medication list. Long-term control medications are your inhaled corticosteroids, your LABAs, your leukotriene modifiers, non-steroidal anti-inflammatories, theophylline, immunomodulators, and daily oral steroids. Your inhaled corticosteroids are early intervention, can improve asthma control and lung function, may reduce symptoms and use of quick relief medications. They reduce frequency and severity of exacerbations, and they're preferred treatment of persistent asthma at all levels of severity. They are the most potent and effective anti-inflammatory medication currently available, okay? And they are used long-term control of asthma. So this is just a list of the different ones that you will see. I will say Qvar is what I use most right now because it's the best coverage. It used to be Flovent. Those kind of switch back and forth. The other ones tend to be more expensive. Inhaled corticosteroids can be dosed at low, medium, and high. Most benefits occur at the low to medium doses, though. The effects is anti-inflammatory. They decrease hyperresponsiveness, decrease secretions, and restore integrity. They improve lung function, and their early intervention is more effective. This is just an image of what they can do in regards to decreasing inflammatory response. And you can see this is a pre and a post 3-month treatment. With inhaled corticosteroids, inadequate prescribing by providers leads to inaccurate determination of persistent disease, and they're a safety concern. Inadequate taken by patient are reluctance to use of daily therapy, fear of steroids, so you have to let them know that the inhaled corticosteroids are not systemic, okay? They are not anabolic steroids, and the lack of perception of effect. So this is just another picture of showing the ratio of deaths with use of inhaled corticosteroids, okay, long term. Um, the provider educator action is we want to teach the patient about the daily onset of action, delay onset of action. So these are not acute, they do not work instantly, they do take time to build up into the system. Teach patient that they are everyday medication. You want to demonstrate proper technique to make sure that they're getting the medication in the lungs and not just in their mouth. Have the patient demonstrate the technique. Instruct the patient on the use of a spacer, which every patient, adults too, should be given a spacer with their inhaler. You want to instruct the patient on rinse and spit after use. So I tend to tell my patients to remind them to take it twice a day. You brush your teeth twice a day. You take your inhaled corticosteroid twice a day. I tell them to take their inhaled corticosteroid before they brush their teeth in the morning and before they brush their teeth at night. That way, after they take it, they're brushing their teeth and rinsing out their mouth. You want to teach the patient when to change canisters. The nice part too is that these medications do have a number. So you want to show them the number and show them when it's getting to the lower level. That's when they want to call in. So I usually tell them when it gets to about 10, go ahead and call in to get your refill. Combination therapy, long-acting beta agonist plus an inhaled corticosteroid may lead to improved lung function, reduced symptoms, reduced supplemental short-acting beta agonists, which we know the overuse of short-acting beta agonists can increase the risk of asthma death. Greater improvement than by adding a leukotriene modifier or a methylphenidate or doubling the inhaled corticosteroid dose. Recommended for adults and children over 5 with moderate to severe persistent asthma. So inhaled corticosteroid plus LABA, these are some of the combinations you can get, like Advair, Symbicort, so you don't have to, they're already combined. The goal of asthma education is to encourage self-management, which means giving patients the ability and knowledge to manage their asthma with guidance from healthcare providers. Do patients who are offered training and self-management do better with their asthma than patients who are offered the usual care? Yes. Okay. A Cochrane Group review of 22 studies concluded that there were significant benefits to intervention groups in terms of reducing morbidity and reducing use of healthcare services. The effects were greatest where the intervention involved written self-managed action plans. This is why I say in our adult patients, we should be giving them asthma action plans. So provide self-management education about monitoring their asthma with their asthma action plan, educating them on how to use their peak flow meter so that they can monitor their green, red, and yellow and red zones. Written asthma action plan, medication technique, and environmental control. Environmental control includes avoiding of triggers, using of even bed covers to prevent dust mites and help reduce that, keeping their house clean and tidy to keep dust levels down. That is the end of our lecture on asthma.